Thank you for being with us here today. Could you describe your research for us?
Well, we'd been started to think about mortality and fertility in Africa for quite a while, and I'd done a lot of work in rural areas. But we realised we actually knew much less about the urban areas in Africa than the overall population or indeed the rural areas. A lot of the surveillance sites and detailed studies are rural based. And of course urban populations are harder to study because of the mobility and the migration component. So building on the work that we'd done on reproductive health in rural Gambia, I started with colleagues in Accra to consider whether we could look at the same sorts of issues around reproductive health in Accra. The steering committee that we set up of Ghanaians from different professions, including university and service people, were very clear from the outset that they wanted a profile of women's health, broadly defined, not simply focusing on reproductive health, which meant that we did two things which I think have been beneficial to the research. First of all, we did include much broader aspects of health, but also we extended the sample to include older women. And very often fertility surveys, the DHS and other such surveys, only deal with women of reproductive age. So getting some insights into these older women and what happened further back in their lives has really been instructive. So those were really the motivating factors in getting going. Now you asked about how this fitted into the general interest in welfare. It turned out that our colleagues in Ghana, directed by Professor Ernest Aryeetey, who is now Vice-Chancellor of the University of Ghana, is an economist by training and was the author of the Human Development Report in Ghana, himself was very much interested to see how various shocks, health shocks as well as other shocks, drove households into poverty. And so that general idea then set us thinking about ways in which we could capture some of the day-to-day costs about reproduction and women's health maintenance, the term that we invented to deal with some of these issues, meant that we could then have some professional inputs on how to do this properly on the ground.
What are some of the key findings so far?
Well, I think there are several. There are two main areas that I think the study has highlighted. First of all, describing health, which is really poorly done in many surveys. There are exceptions with the World Health Survey and others, but in the standard DHS, there's really very little on adult health. There's some attempts to measure maternal mortality and adult mortality, but the focus is generally on children in terms of health. So what we found are some surprising results. First of all, the women are in generally quite good health. And on standard measures of self-reported health, they compare quite well with, say, the equivalent women in Europe or in North America matched for age. What we do see is a very sharp age gradient in health. And so after roughly the menopause, Ghanaian women are apparently much less healthy than their equivalents in Europe and North America. But one of the key findings about their health is that they are really in the grip of this non-communicable disease epidemic. And so obesity levels in this population are roughly the same as amongst the African American population in the US. And they are much more overweight than their European equivalents. So this is an astonishing finding for a population that has a moderate level of income, hasn't gone the fast food route. These are traditional foods, but clearly things have happened both to the volume of food being consumed, but also in terms of activity patterns, which have meant that the principal cause of death now is not malaria or the common tropical diseases, but it has cardiovascular disease. So this was a rather surprising finding. And linked with that, another non-infectious disease was the common prevalence of mental health and depression issues. And again, this was new, I think, in an African population, but we are finding that even amongst women of reproductive age, in both rural and in urban Africa, typically between 10 and 15% of women are clinically depressed to the point that if they were here in the US, they would be under drug therapy for their depression. So it's that serious. And clearly, any disease which has a prevalence of something like 15% is a very important factor. So that's the health side of things. And there were many surprises in that. The second really major surprise was the very low fertility. Because as we've shown in what we've written, the women of Accra have collectively decided to have very small families. In fact, they are very close to replacement levels of fertility. Now, they're doing this in a peculiar way, and it's not by the widespread use of modern family planning. The current prevalence of modern family planning methods is less than 40%, which doesn't square with a total fertility rate of about 2.3. Now, of course, people think that Ghana's liberal abortion laws are part of this story, but from what we've done in clinics and looking at admissions to the hospitals, we cannot find enough abortions to bridge the gap between what we would predict from the levels of modern family planning use and the realised levels of fertility. So Ghanaian women are finding other ways of managing their fertility, including staying away from their partners, avoiding intercourse in different circumstances, and something like a third of the households in Accra are female-headed. And it's quite common for married couples not to live together. So there are features of this low fertility which I think are important for other places, because it shows very clearly that people made their minds up about what their ideal family size should look like. And it's almost as if the family planning services are somewhat peripheral to those aims. And that's perhaps some lessons for programs and action in the future.
Well, that leads into my next question, which was, how do you think these findings can be used to support more effective population health and development policies?
Well, I think, first of all, putting the information in the public domain is helpful for perhaps laying to rest some of the myths that we have about the health and welfare of people living in the tropics. That, of course, the tropical and infectious diseases like malaria are still salient, but they're by no means the only important feature to be addressed. And just as in our population, it looks as if to move ahead with some of these problems associated with the obesity epidemic, for example, we're actually going to have to focus much more clearly on behavioural change, but behavioural change for the population as a whole. Because being obese is not like a dichotomous variable. You're not overweight and underweight or normal and abnormal. There is, we know, a dose response in weight, and all of us could be much thinner and in much better health as a consequence. So I think that these kinds of changes are going to require mobilization of the whole population, include some of those younger women who are not terribly obese at the moment, but it seems that they have a strong risk to become very obese later in life. I think the other thing that has happened between the rounds of the survey was Ghana introduced this national insurance scheme for coverage of a certain range of health services. Including a brief period when fertility, or at least deliveries, were free in hospitals, which led to a huge overcrowding of the maternity facilities because people didn't have to pay, but there was no matching improvement in the quality of the services or in the number of people there to help. So in that area, I think we have to think about ways in which reproductive health in particular can be protected. Obviously, the liberal abortion laws do mean that the bulk of induced abortions are carried out in safe conditions. That's one striking feature. But it does put a burden on the health services. If people are not using modern family planning methods, there will be always a demand for dealing with unwanted pregnancies, and the services will have to gear up to deal with that demand, because, as I say, women are preferring families of 2.3 or thereabouts children. I think the perspective that the data provide on things like the uptake of the national health insurance, which a very critical Oxfam report has pointed out as being selectively used by the better off, not by the poor. We can document those kinds of differences in uptake of the insurance scheme, and perhaps there's new legislation in front of Parliament which is designed to modify some of these conditions. But one of the things that's missing in government policy, and including the legislation around the National Health Insurance Scheme, is the financing of prevention. So preventative care of different kinds, preventing people getting obese, preventing people getting STDs, preventing people having unwanted pregnancies. Those are all not very well developed at all in the current policies that the government has in place. So we're hoping that some of this evidence might be used for reshaping the changes to the legislation that are currently in front of Parliament.
Thank you. Allan, could you tell us a bit about the economic links and things you've been exploring through your work?
Yes, certainly. We were convinced that illness more generally had an effect on household income. And so we took two different approaches. One was to, over a course of a year, encourage a sample of the women to keep detailed diaries of their activity patterns, including illness patterns and illness patterns of other household members. And we've learned a couple of things from this source. One is just how many hours a day women put in to work. And secondly, how they manage reproduction in the context of their work. So we find, for example, that they take very little time off work after a delivery and when pregnant. And so we find that 67% of the women, roughly speaking, are self-employed, and so they're taking their children to work and breastfeeding them in situ. So there's remarkably little interference with the women's work patterns, but they are at full stretch in terms of the work they're having to do. But in addition to this idea that illness, whether the mother's illness or the illness of other household members that she is responsible for, plays a role in affecting household income. With Gunther Fink, who was the economist in charge of this data gathering, and our reproductive health specialists from Ibis Reproductive Health, Kelly Blanchard and Naomi Lintz, we've actually collected quite a lot of information that maintaining good health, not just dealing with sickness, is also quite costly for these women. And so, for example, the routine costs of menstruation, where there are a certain number of taboos around what women can or cannot do when they're menstruating, and indeed the routine costs of family planning services are actually quite a large part of these women's expenditures. And I think this is the aspect about the connection between reproduction and household living standards that's often missed. We forget. We certainly look at the catastrophic things like maternal deaths, perhaps serious illnesses, but some of these routine costs are also quite substantial drains on poor women's budgets.
Thank you so much for coming here today and talking about your research.
Thank you.